Hello, everybody. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host. Welcome back if you are a friend of the foundation and of the show, and welcome if this is your first time. My name is Rain Bennett. As I said, I'm a filmmaker, speaker, and writer. I've been working with CCF for a decade now. The first work that I did with them was when I was living in New York, as I was just talking to my guest about the good old days back in 2011, and I started doing we had a big series that we did for CCF that year, and we've now updated that series. We covered a lot of ground in both of those, but I've been producing video content for them for 10 years, and now which we were doing these Facebook Lives before the pandemic, but the pandemic gave us the opportunity to do them weekly and create this show, which I'm very excited about. But all of the work that we have done and all the work that CCF does has the same mission in mind, which is to educate people and raise awareness about neuroendocrine tumors. That is the goal. That is the mission. And I think another big part of their mission, and it's evident in this show, is to cultivate this community that is so apparent and clear when we see this show going on, and that's the part that I'm so thrilled to be a part of. So welcome to the show. Before we get started, we always like to thank our presenting sponsor, Tercera Therapeutics. There's absolutely no way we could do this show without them, and we always like to include this disclaimer at the top of the program before we get started, and that is that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. That is the takeaway, that last line. That's what I want you to listen to. We're going to give you some good general advice. We're going to hopefully answer some of your questions for this journey, but by no means do we know your specific case. So take this information to your home team who does know your specific case and make the best decision for you moving forward. So today our guest is Dr. Diane Reidy-Lagunes. How are you, Dr. Reidy?
I'm doing great, Rain. Thanks so much for inviting me.
Yeah, I'm excited to dive into it with you. But before we get started, for those that don't know you and what you do, where you work, tell us a little bit about yourself and the role that you fill here in the neuroendocrine tumor community.
Absolutely. Well, thank you again it's really an honor and privilege to be here today during this lunch hour. Like you said, my name is Diane Reidy-Lagunes. I am a medical oncologist at Memorial Sloan Kettering Cancer Center. I'm coming live from the Upper East Side of Manhattan. My daughter got her second vaccination and wasn't feeling good today, so I'm home, like so much of our country and the world. But I have dedicated the last 15 years of my research and clinical care into focusing on the care of patients with neuroendocrine cancers. So it's an absolute honor and delight to be here today. The people that are on this call are the reason why I do what I do every day. And we've built a really powerful program at neuroendocrine at MSK, where we're, again, trying to focus on the treatments of today and tomorrow, but also really ensuring that the care that we receive is all about the quality. So it's quality and quantity. So I just love what you stand for and why you're doing this, and super excited to join you.
Yeah, I love that line that you just said, and we're already aligned because we talk about that quality of life quite a bit on this show, and it's really important to all the patients that we have. Everybody that is in the comments, I see you letting us know where you're signing on from, so you know what to do. If this is your first time, tell us where you are in the world. We love to see how far this program reaches. Inevitably, every week live, we have people tuning in from all over the globe, even when they should probably be asleep. So that makes us feel like we're doing our job well if they stay up late to watch the show. We're very, very appreciative and grateful. Yeah, Dr. Reidy and I were just talking about my days. I had some days in almost the Upper East Side there, close to the East River. So we were just reminiscing about how amazing that space, that place is. But also big thanks to your daughter for sharing you with us for the hour, and I hope she feels better soon. So everybody, how the show goes down, if you are a newcomer to the show, go ahead and send in your questions. Like we said, we're going to do our best to give you good guidance. We can't get too case specific, so try to be general in your answers. But just know that if you have follow-up questions, you can still send them in the comments as the show is going on. However, we get so many questions, inevitably we can't get to them all. So if we don't get to your question, or if you have a follow-up question, I urge you to reach out to Carcinoid Cancer Foundation. You can message them privately here on the Facebook page. You can also visit their website, carcinoid.org. They will get you the information that you need, I promise you. Or if not, they will get you the person or people who will get you the information that you need. So make sure you reach out. And also, this show will live here. It'll be evergreen. It'll stay on the Facebook page under the videos tab. And begin starting Monday, we will republish this episode to YouTube for those who don't have Facebook. So before we get started, there's two asks that I have of you. You all have been doing a great job of this, and I appreciate you for it. One, the main value of this show is the interactive nature, right? This one-on-one, this virtual one-on-one session that you have with an expert. Okay. Of course, you can watch this show a week from now and get a lot of benefit from it. But having this moment where you can ask a question that's going to help you with your journey is the main value. So if you know someone who would benefit from this, could be a patient, a caregiver, a support group leader, anybody in the NET community, let them know the show's going on now. Remind them. You can tag their name in the comments. You can also just share the video to their page any way you can. You can text them if you got their number and let them know the show's going on. Let's get as many people as we can here to benefit from this. And secondly, this part is very helpful for me. If you see a question in the comment section that you also have or you're interested in the answer to, you can like it or love it or any of the reactions that Facebook gives you the option to use. They all effectively work the same for me, which is to upvote it. It lets me see like, hey, 6 people have this question, and it shows me there's a demand for it. So I'll make sure to get it across. So those are two things you can do to help me do my job better, which is of course to help you. Finally, before we get started, have you downloaded CCF's free NET Cancer Health Storylines app? This app is awesome. It makes it very easy to record your symptoms and your medications, your nutritional concerns, which I know people have all the time, your moods, all of that. So we'll put the link in the comment section. Check it out if you haven't. And to that point, if Dr. Reidy refers to anything today, a medication, an article, any resource, we'll try to our best to get that in the comment section too. So you don't have to go open a Google, a new browser window and Google whatever it is that we're talking about. We'll do the hard work for you. So tell me a little bit, Dr. Reidy, about your introduction to this disease. Like when you started working, did you go immediately into this field? How did you end up working with NET patients?
Such a great question, Rain. So when I started, I came on faculty in 2008, and my mentor had focused mostly on colon cancer research and clinical care, but he had this small niche of neuroendocrine cancer patients. And, sadly, there was just not a lot of trials and research that were going on at the time. And there was something about that patient population. I think in part, I'm always most comfortable at the bedside. I said, I love research, but I'm always sort of much more comfortable being with the patients. And particularly in our patients with neuroendocrine cancers, like we're going to be on this journey for a really long time together. So again, it's back to that quality of life where you really start to develop important relationships. And so I think I really got interested for a couple of reasons. First, I wanted to be part of making sure that our patients with neuroendocrine cancers also had the trials and the science that was being tested, that we weren't doing stuff based on anecdote. There were some amazing people that worked in this field for a very long time, but they weren't, quite frankly, doing the right science and doing the right tests to prove what they were doing was accurate. And so I wanted to sort of bring all the sort of tools that I've learned from being a fellow at MSK to the neuroendocrine world and conducting clinical trials. And at the point, James Yao and Matt Kulke, like some of the big clinical trialists, were really starting to develop some really great trials. And they actually became a mentor for me. And so that was one of the most important sort of pieces of why I wanted to go into this field. And then the second one, again, is, as we said, like the quality of life was so important. And I was finding that, patients like, you got to get surgery, you got to get surgery. And, for many of our patients, surgery is important, but it absolutely is not a one size fits all, and it helps for everyone. And I was finding that many patients were getting these huge surgeries, and then they were getting real hard side effects and troubles and other things. And so again, it was sort of this opportunity to work with so many departments, our surgeons, our interventional radiologists, our endocrinologists, our gastroenterologists. And I really liked working in that collaborative team to be able to care for our patients in the best way possible.
That's a good point. And we talk every week about the importance of a multidisciplinary team and approach to this disease. So I like that. And a lot of people, I think, share that. And then we also had Dr. Kulke on here. I guess it was last week, maybe the week before. Yeah. So
So yeah, so I mean, I sorry, I was just going to add. So I mean, I think so that piece of working as a team was really important.
Yeah.
And again, the last piece of that was to also sort of think about how we could develop as a team the research we needed. So, many cancer centers of excellence for neuroendocrine cancers, including MSK, have the ability to have fellows, for example, that we really want to train. And I was able to have my own fellows that are now in faculty for neuroendocrine cancer, some in the lab, some in the clinic, helping me to develop that team. So that was a very exciting opportunity to sort of build a program in neuroendocrine cancers, not only with the team members at MSK, but also the sort of future generations, which was great.
Yeah, absolutely. I mean, building that, like, what you need, and like you're kind of putting together your own all-star team, it sounds like. What are some of the questions, like, what are some of the initial questions you ask a new patient with a NET tumor? You've talked already about how important that is to you, the bedside, working with the patient. Where do you start?
Yeah, I mean, I often tell my patients, there's a couple of things I use, if you will, to better understand that patient, but also the disease that the patient has, and there's a lot of times like patients tell me, oh, well, they tell me this is the good one to have, or that I'm so lucky I got this. Like, no, this is a cancer and no one should ever have this wished upon anyone. Thank heavens it's a cancer that is slower growing than most cancers that I take care of. So our patients can live for years and often sometimes decades, which happens in our clinic all the time, which is wonderful. But it's obviously, not something that you ever want to have. But there's a couple of clues that I use or pieces of information that's very helpful for me to better understand the patient that's in front of me today or in that moment, to understand like how worried should I be about this neuroendocrine cancer. So the first thing I do is I look at the patient. Some of our patients can be quite sick from this disease, and they could lose weight and they can have a lot of pain and they can be not feeling well, where on some of our patients, look like $1 million and you never know in a million years if they have this. So the sort of performance status of the patient can be very helpful for me to understand what we call the biology of the disease. How aggressive is this cancer? Is it something that's potentially growing fast or not? The second thing we always say is like what your cancer looked like under the microscope could be very critical for us to potentially make our best guess on how this may behave. Is it going to behave, in a sort of typical, hopefully slower growing way, or is it going to behave in a more aggressive way where we may need to do treatments earlier rather than later? And then the third thing we ask is, again, are you symptomatic? Does this tumor make hormones? Does it not make hormones? Are you starting to feel some of the symptoms because maybe there's burden of disease? So that could be also helpful. And then the last piece is that sort of PET dotatate. If you had a PET dotatate, where is the disease? How much disease do we have? And does it light up? We sort of say like a Christmas tree, if it's a very avid or not. And that, again, we only use, and it's not mandatory, you have to get a PET dotatate on everyone, but in patients with a lot of metastatic disease, we like to get that as a baseline to help us guide treatment. So there's a couple parameters that we like to use to help us better understand and guide that patient, because we know, obviously, not every patient is the same. In fact, every one of our patients are different. So that personalized approach becomes really important in defining how we're going to dictate that treatment and care.
Absolutely. Well, folks at home, friends of the foundation, the numbers are looking great. So you all are apparently doing your job. We got people from all over, a lot of people from Canada, from Texas. We have Ernesto from Mexico, says my last name is Lagunes. Not sure if we're related, doctor.
Hola, Ernesto. Encantada. Qué bueno.
Lori from Long Island said, but cared for at MSK. Hi, Dr. Reidy. Yeah, this is looking good. I saw somebody, Rita from Tyler, Texas. Isn't that where Jamie Foxx is from? I'm pretty sure. Random little.
That's a random fact that you know.
Yeah, but we got a lot of questions already coming in, Dr. Reidy, so I'm going to go ahead and start taking some questions from the audience.
Ask away.
All right, let's start with Diana, who says, "Hi, thank you for doing this. Question: does Sloan do a generic testing for people with neuroendocrine? And second question, is the new copper 64 scan better or clearer than gallium 68?
Oh, great question. So I think she may mean genetic.
I thought so too.
For neuroendocrine.
Agreed.
So we do test genetics for neuroendocrine. As many on the call probably knows, there's two reasons why you may want to get, quote, genetic tested. The first one is you have a strong family history of neuroendocrine cancers, which is pretty rare. Less than 5% of our patient population have an inherited gene that could have contributed to the disease development. That is, there was a gene that either mom or dad had, it was passed down to our patient with neuroendocrine cancer, and now we want to confirm if that gene is there. And then if that gene were there, then you're sort of the map to have implications for your immediate family members to decide if they need to be tested or not. So again, if we found a gene in you, then we would say maybe at some point, if you have children, they'll need to be tested, or your direct family members like parents and siblings would need to be tested. So that's pretty uncommon. Again, those traditional genes are something called MEN1. In pancreatic neuroendocrine tumors, it's a little bit more common, something called VHL or NF1. But in general, thank heavens, they're generally not passed down from mom and dad, which means that the chances of other family members having it is low. The second reason, which is much more sort of commonplace now, is to test the role of the genetics in the tumor itself. That is to say, okay, this wasn't from a bad gene that was passed down from mom and dad, but something happened in these cells to cause those cells to get damaged. And when those cells get damaged, we call that mutations, because it's the gene that actually got damaged, which eventually caused this cancer to develop. So we've done a lot of work on, in fact, most of my career, and Dr. Raj, who's my partner, has done a lot of work on this as well, to test the what I would call clinical utility of genetic testing for neuroendocrine cancers. And what we found, unfortunately, is that there aren't a lot of what we call therapeutic genes, meaning we're not really going to often find a gene that you can target and treat. That we haven't found. We have found that certain genes, so the presence of certain genes is a better thing, meaning if you have certain genes, it predicts that that cancer will behave very well, or better, I would say, than if you didn't have those genes. And then there are certain genes that we found would predict a potentially more aggressive outcome. So we call that a prognostic effect, that if you test the genes, they can help us decide, okay, I'm a little bit more worried about this cancer or not. But we don't, unfortunately, in 2021, have yet identified therapies that we can use to alter the treatment based on that genetic profile, if that makes sense.
Got it. And the second part of that question was the copper 64 scan versus gallium 68 clearer.
Yeah. I don't think that we necessarily think it's clearer. It's an alternative. We know that both of those are better than the so-called Octria scan, the old traditional Indium 111 Octria scan. So the copper is like just coming onto the market now. So to be honest, I don't know where it's going to fall into play for us. Most of us are using the more common PET dotatate right now, but I would expect that the copper would also be an alternative therapy or alternative scan to potentially use. Again, these are all to just look for the receptor and make sure that it's there, as opposed to a therapeutic reason to use the copper.
Got it. Thank you. And thank you for your question. Next question from Sharon. This is an interesting one. How often do you see women with NET cancer also diagnosed with endometriosis? And are gynecologists sometimes part of a multidisciplinary team?
Hey, Sharon, that's a great question. I don't necessarily think that I would say endometriosis per se is common with NET. I will say that often, as many on this call know firsthand, sadly, no one's thinking about our disease. And so it can get undiagnosed for a very long time. And so young women in particular that have a lot of pelvic pain, eventually through the endometriosis workup, we identify these neuroendocrine cancers, but I'm unaware of a correlation of the presence of endometriosis with this disease. I think that's probably true unrelated.
Got it. And everybody, I saw that you don't see this, Dr. Reidy, but I just saw a flood of likes and loves coming through. This actually helps very much if it shows us visually that you're getting good value out of this. Dr. Reidy is answering your questions and it's helpful. So I like that. If you get a good answer or something that you like, you can just hit that little like button or love button. It lets us know that we're doing a good job. And now there's a ton coming in. Now that I've
I'm feeling the love, Rain. I'm feeling the love. I love this. I'm gonna do this every day. Bring me back.
Yeah, let's go next week. Awesome. All right. So Karen and seemingly many other people have this question. And I know people have this question. It comes up a lot. So we'll see how you feel about it. Do you know if cancer is sugar driven? We all have
Oh,
always heard, cancer loves sugars. Where's the
yeah.
truth in this
I
statement?
love that question. So a quick plug. So because exactly what you're doing, Rain, and because I believe so strongly in educating our patients and empowering them to make the right decisions, as are you, I actually recently started a podcast called MSK Cancer Straight Talk.
Awesome.
And the hope and expectation is that a lot of the questions that come out in clinic, or quite frankly, don't come out because we don't have enough time, but they're questions I know are on our patients and their caregivers' mind, or what we're addressing. So questions, for example, about the role of nutrition and sugar is actually a podcast that we did with a wonderful oncologist in lymphoma who actually has spent his whole career focusing on sugar and the role that it plays in cancer, and could we actually alter the diet or what we eat to potentially help either prevent cancer or help treat it. And I think the bottom line is the jury is really still out. There's no question that eating well, like we all know, is going to be helpful. It keeps our immune system strong. Exercise is critical. I'm a huge advocate for making sure that our patients exercise 3 times a week, at least for 30 minutes, and eating probably a plant-based diet. But I think that what we found, for better or for worse, is cancer will eat anything we let it. If there's sugar there, it takes it up. If there's fat there, it takes it up. If there's another cancer cell there, it takes it up and eats it. Wow. So it doesn't necessarily, preferentially take up that sugar and then we're driving the cancer to grow, but rather it's just cancer wants to eat and get its nutrition from wherever way it can. So that's why we want to emphasize the importance of eating well, probably, less red meats and saturated fats and simple sugars and processed foods, and more of that plant-based fish, chicken type of diet is just a win for many things. And so we have one talk on the podcast on nutritional health. We call it metabolic health, and another one all dedicated to sugar, but I can give you the Cliff Note version for those that are old enough to know what Cliff Notes are, and saying that, that you certainly can have sugar in moderation if you want to have an ice cream cone, if you want to, but we don't want you eating processed foods all day long.
Yeah, even cancer likes candy, I guess.
Yeah, that's right.
So the podcast name again
is MSK Cancer Straight Talk.
Got it. And is it through MSK?
You could listen to it anywhere you listen to your podcast. So Spotify,
but I mean,
Apple.
Is it like an official MSK?
MSK has helped sponsor it. That's exactly
awesome.
Right.
Yeah, that's killer. And it's available anywhere.
It's available anywhere that you listen to your podcast.
Spotify.
That's right.
Spotify, cool. We'll try to get a link to that if we can. But that's awesome. And I think that I'm not sure how many other ones are, but that's such a good use. This is an aside. I'm digressing for a moment, but such a good use of the information that you all have. I mean, I'm filmmaker, writer, storyteller, right? So I love being able to use new media to do that. Podcasts are such an effective way to get stories and information like that across. So I think that's such a great idea. And I hope that other institutions follow that lead. I know some do, but I also know podcasts for some people are still kind of it's been around for over 10 years, but it's still kind of a new thing.
Exactly.
Right.
That's right. Yeah.
But it's a good way that people like to digest information.
Yeah, and I think that, it came from many reasons. One, just like what you're doing today, we wanted to educate and empower all patients that have been touched by cancer, including, caregivers. But two, there's a lot of myths out there. So how do we debunk the myths? How do we know, how do we untangle that confusion of figuring out what's real, what's not real? So hopefully, this will be an opportunity for folks to listen to, what is the real deal on, for example, fasting? And, there's a study that just came out that said people that did that intermittent fasting actually did worse. So that's an important information to know, that intermittent fasting really does not help cancer patients.
Certainly not a cure-all.
That's important. Not a cure-all, for example.
Yeah,
exactly. But I think that these are really great conversations for all of us to have. Next week, we're actually going to do one on sexual health, stuff that, very important for our patients that we just don't often talk about in the clinic, and we need to.
Yeah, that's, I think, especially important, the conversations that aren't always talked about in the clinic, because there are so many of them to be had. And I also think a lot of people just learn better in this conversational format, or many people do. I think it's a totally different thing. And I think that's a lot of the reason for the popularity of podcasts right now. It's a totally different learning style than just hearing it from your doctor or reading it in a textbook, right?
Yeah.
Okay, let's keep moving forward with the questions. Bonnie says, greetings from Arizona. Hello, Bonnie. How often, this is a broad question, so we'll see how we how we address it. How often does a carcinoid tumor recur?
It's a great question, Bonnie. So it's sort of what's in a name, right? A lot. And so we call carcinoid tumors, that's sort of an older fashioned name, if you will.
Yeah.
We tried to say neuroendocrine, and where did it start? So where it start matters. So these are cancers, as many of you probably know, they can start anywhere in our whole body. They most commonly start somewhere in the GI tract, like the pancreas or the small intestine or the large intestine or the appendix. Sometimes in the stomach as well as the lung, but they can also develop in the GYN systems as well as GU, like the kidneys and the different parts of the GU system. So, and even sometimes they're been found to report to start even in the liver. So where it starts actually can tell us a better understanding of what the risk of recurrence is. So for example, an appendix neuroendocrine or carcinoid, the chances of that coming back is exceedingly rare, which is awesome, right? Small bowel, again, the chances of coming back is also rare. The presence of it in the lymph nodes, we get worried that it could come back because if it kind of jumped over to the lymph nodes, there could be cells still floating around. But importantly, I have patients that have had, a dozen lymph nodes involved and the thing never came back. Pancreas and lung, again, depending on what we call the grade of the tumor, which I'm sure you all know, they may have a slight increased chance as comparison to others. So I think one of the biggest struggles with our disease, as I've sort of alluded to before, is every patient is different, and what we call the range or the standard deviation of the chances of it coming back is huge. So some of them, no matter what, even in the setting of metastatic disease, it just never comes back. And some of them, unfortunately, it's within a shorter period of time. So it does depend on where it was when we first found it, and then what we call the grade of tumor. So what those cells look like under the microscope also give us a better understanding of the chances of it coming back. In most diseases, though, I would say most cancers actually, the first 2 years is pretty important. So most of our cancers, if it's going to come back, it tends to be within the first 2 years. So for our disease, because it's slower growing, it can take much longer, but that first 2 years is pretty critical. And if you're out of that window, that's actually a really good thing, because that tells us a couple of things. One, the longer it takes for it to come back, the more we know it's actually much more treatable, and the biology of the tumor, if you will, is much more, it's much slower. So if it took it 5 years to come back, obviously we never wanted to see the thing, but if it took 5 years to show its ugly head, often, not always, but often that's a slower growing cancer that's easier to treat.
That's a good point to consider. Folks, if you are just joining us or joined us late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. Today, our guest is Dr. Diane Reidy-Lagunes. We're going to keep moving forward with questions because we got a lot of them. Next question from Denise. This is maybe a follow-up to the previous question, but this is it common, or how common is it to have multiple tumors? I have 2 on my liver, 2 on my spine, 1 on my rib, and 1 on my pancreas.
So it's pretty common to have disease that has already spread to different organs without knowing it's even there. And that's one of the most unsettling parts of our disease, in that very often, because it's slower growing than other cancers, it can spread without us even knowing it's even there. And so it's very unsettling for a patient to know that they didn't have any symptoms, and before they know it, it can travel to the spine or the rib or the liver. So that's pretty common. Unfortunately, in my clinic, I see it all the time. It's still very treatable. So I'm sure you're in great hands, Denise. And, I think that when it spreads like that, we have to watch to see what the disease is doing. And so usually scan to scan, it can give us a better understanding of, is it starting to misbehave, or it's just kind of hanging out in those places and not doing much? Because that's very possible. Sometimes it just hangs out in the rib and the spine, doesn't do anything.
Yeah. Next question from Kim. Kim says, how effective have you found chemoembolization to be? My dad had the right side of the liver done already, but the recovery was terrible for him.
Yeah.
And so they're advising him to do the left side, but he's apprehensive.
So Kim, that's a really important question. And so there, I should say that, there are a couple of different types of embolizations for people that have undergone them. I'm sure they've heard about it, but for those that have never had to do embolization, the different types are radioembolization, where the interventional radiologist places little beads. They do that in the operating room, but it's an outpatient procedure. You can go home after it. Or the bland embolization and chemoembolization. So there, the idea is that it's kind of cool concept where the liver has two blood supplies. One is called the portal vein and the other one's called the hepatic artery. I don't know if you've talked about this on other shows, Rain, but the idea is that for whatever reason, 90% of the time, 90% of the liver gets all of its blood supply from the portal vein, whereas the tumor gets all of its blood supply from the hepatic artery. So if you block off that hepatic artery, you can kill the cancer by depriving it of its blood supply, by killing it and not allowing it to get any of its nutrients. But you are able to do so because the rest of the liver, it's getting its blood supply from the portal vein. So that's really cool. And so the bland embolization is you just shove particles up in the hepatic artery and block it, and then the cancer cells die. Chemoembolization is you shove chemo and then you shove particles and then you allow it to die. There's never been any data to suggest that the addition of the chemo helps more kill, if you will, that help kill the cancer anymore. So most studies, unfortunately, weren't comparing one-to-one. There is a study ongoing right now that we're participating in called RETNet that Dr. Sulin is running at the University of Pennsylvania. And we're one of the centers where we're actually asking that question. Does chemoembolization versus bland embolization matter? So we won't have that answer yet for a little while, but I think what's appropriate is, one, you want to make sure the interventional radiologist that's doing these different types of therapies is very comfortable. He or she, like, I know how to do this, because you want to make sure that they are comfortable and talented and technologically skilled to do chemoembo versus bland embo. I think if he had a really hard time, it would be very appropriate just to do bland embo, but it would also be very appropriate to not do anything. In fact, I would encourage to just hold off until he turns the corner and gets better. You know, I think that most interventional radiologists would totally agree with that. What we don't want is to obviously kick a patient when they're down and not allow them to recover. And then, you know, we can get into trouble. And, you know, these procedures are pretty safe nowadays, but they do have very rare and serious side effects, including risks of infections and other things that can happen. And then you have drains, and it's kind of a mess. So we want to make sure that anytime we go in to do the other side, which is commonplace, a patient is recovered to a place that we feel comfortable that they're ready to go back in for the second one. I would just add, thankfully, usually we do, you know, the right side usually has more disease. It's a bigger compared to the left. So it's not usually as hard when you do the other side.
Okay.
But again, you still want to be ready for it.
Got it. Awesome. And no, we haven't talked about that before on the show, not to my knowledge, or at least not with that clarity. I got to say, you do a really great job of explaining things and visually too, so that people can understand it, or at least simply is a big thing when it comes to clarity and you know, conveying information. So you've done a great job of that. And I also really like that you laid that groundwork with just the three different types of embolization. I appreciate that, and I'm sure the patients do too. Kim, thanks for your question. Hopefully that helps. Next up, Andrea or Andrea, have you ever seen, and a couple of people have this question, do you ever see loss of hair or slow growth of hair with NET patients? Is that something that you're familiar with?
That's a really great question, Kim. So we have seen it after PRRT. For those that have had radio-labeled octreotide or octreotate, you can get some hair thinning and rarely hair loss. I have had some patients that swear that after they started the somatostatin analogs, either lanreotide or octreotide, they had some hair thinning. We always want to make sure that your thyroid function tests, your thyroid TSH is checked just to make sure, because being on those drugs for so long could sometimes alter those hormones, and that itself could actually lead to some hair thinning. So I don't think the disease itself would cause hair loss or hair thinning, but some of the treatments may. So you want to just be mindful and talk to your oncologist about that.
Got it. Next question from Rebecca. What do you think of immunology treatment for metastatic, well-differentiated neuroendocrine tumor cancer?
That's a great question, Rebecca. So we've tested multiple studies. We had a lead site here at MSK and others. Unfortunately, the immunotherapy drugs that work so well for melanoma and certain types of breast cancer and kidney cancer and liver cancer just have not proven beneficial in our disease. I think we all wanted more than anything to be able to offer those therapies because the side effect profile is so good, and when it works so well. But there's something about our disease that it just doesn't typically respond. There was one study in what we call poorly differentiated neuroendocrine carcinoma, which are very aggressive cancers, and that looked like perhaps there was a signal, but subsequent studies just haven't been able to show that. And so I think the jury really, unfortunately, shows that the role of immunotherapy in neuroendocrine tumors today is pretty limited, unless you had some genetic inherited mutation, but that's pretty rare in our disease.
Got it. Folks, this is Luncheon with the Experts, Carcinoid Cancer Foundation program. We are just over halfway through today's episode with Dr. Reidy-Lagunes, who Michael says, so incredibly fortunate to have Dr. Reidy-Lagunes as my doctor. And someone else says, Bruce says, hi, my favorite is doctor in the whole world. So we got
I know who that Bruce is.
Yeah. So we got a rock star on the show today, folks.
I love that you guys are on. Thank you. I'm going to have a little of my Jamaica tea. Ernesto, you know what I'm drinking. It doesn't have any sugar in it.
We're going to keep moving along with questions, having a good time today, getting a lot of information. Shane says, what are your thoughts on the surgical resection of primary tumor and Mets?
Shane, that's a great question. And we're actually just about to publish our findings on this. So I think there's a lot of confusion about the role of removing the primary in the setting of having disease elsewhere. I think there's no question that if that primary is causing trouble, like you're not able to move your bowels as well, or you're having intermittent pain, and your oncologist or your surgeon says it's from the tumor, it needs to come out. Because if, God forbid, you get a blockage, it's incredibly painful, as I'm sure people on the call may have had. It's one of the most painful things that patients have to endure, to have a blockage. So we definitely want that out if there's any question that it's causing symptoms and if it can be done safely. The problem becomes, like, what about if we don't think it's causing any trouble, but I find it on the PET imaging and it's this tiny little thing and it's there. Like, could removing that tumor somehow help me live longer or better? And we have no data to say that it can. And so I think we have to be very careful, because every surgery has risks and complications, and it can potentially increase the risk of adhesions. And so I'm sure many people on the call that have been through surgeries know they're not fun, and they can cause symptoms and pain themselves. So I think the answer is, should you always take out the primary? The answer is no. If it's symptomatic or if it's going to cause trouble, should you do that? The answer is yes. Or if it's the only site of disease growing and we're worried about it. So for example, in our patients that have neuroendocrine cancers that start in the pancreas, often for whatever reason, we control the disease because of the embolizations that we talked about, or from other treatments, and it's the only site growing. We often will, for example, if it's in the tail of the pancreas, consider removing it. But as many on the call may know, if you have a tumor in the head of the pancreas, you have to do a procedure called the Whipple. Yep. That's a huge deal, and so there's nothing palliative about that. That's a big ask for our patients to go through. So do I just take out a primary tumor in the head of the pancreas? The answer is absolutely not. And there's a lot of reasons for that. One, because it's a huge deal and it's a huge procedure with risks. But two, if I ever want to do those embolizations like I talked about in the past, or just before, if you undergo a Whipple, you're at much higher risk of infections into the liver by doing that procedure. So we have to be very mindful. Everything we do with the question is why. Just because data may suggest is helpful is not an answer. That's the wrong answer, in my opinion.
I like that. Folks at home, quick little plug of just other content and resources that we have for you. I alluded to this at the beginning of the program. I've been working with CCF to produce videos as well, some patient-centric, some treatment-based. And last year, 2020, we effectively redid, or had a second series come out to update the series that I first did with CCF 10 years ago. And one of the videos that we did, the final one, is you can find these on the videos tab. This released in, I want to say January of this year, is on surgery, a long video on surgery. And what made me think about that was Dr. Reidy mentioned the Whipple procedure, and we do have Dr. Mark Lewis in that video, who is a NET patient and doctor who had the Whipple procedure himself. And if you want to learn more about that, he has a what do you call it? It's not a diagram, a model. And really thoroughly breaks down what the Whipple procedure is in a way that's like super easy for someone, even like me, who's not an expert or a patient or anything, to understand. So little side note, there's a lot of great content that CCF has that can help fill in some of these gaps and these questions you might have. And that's one piece that pertains to what we were just talking about. moving forward. Karen says, do you have any patients who are having more side effects from being on lanreotide 120 mg dose over extended time? I'm going to try to lower my dose to 90 milligrams and see what happens.
Hi, Karen. So I think that the answer is we definitely have patients that have side effects from the drug as opposed to the disease. And I love that question because it's so important, you know. So often, particularly in situations where, you know, maybe an oncologist is not as familiar with the disease, people keep saying, I have a lot of frequent bowel movements all the time. And like, oh, you got to go up on the dose, you know? And so without thinking, maybe it actually is the dose. Maybe we need to take a step back and ask more questions. So as I'm sure many on the call know, often after the shots, you can get a lot of bowel frequency, which is often related more to malabsorption of some of the foods that you're eating, such as fats, and pancreas enzymes and other things can help with the frequency of that. But the cramping and the gas, it's often foul smelling. I tell the partners that it's always my fault, you know, when people have to, you know, unfortunately get a lot of cramping and gas and that kind of stuff, because it's typically the lanreotide or the octreotide. I think that most of our data show that, you know, the studies that are done to show that the cancer can be controlled with lanreotide and octreotide are generally at 120 milligrams for lanreotide and octreotide 30 milligrams. So we really don't have great data on knowing, you know, what we call cytostatic control, how well lanreotide 90 milligrams can work as compared to 120. But in a patient that has very stable disease and, you know, you really feel like, you know, my quality of life stinks and I'd like to lower the dose, I think it's appropriate to try. It's just, we just don't have data to know, like, is 90 milligrams going to be as good as 120 to keep the cancer at bay and keep it controlled. So that's one I would just explore with your oncologist.
Got it. A couple questions on food. Now, we already partially touched on this. Karen and a few other people have the question, what is your view on fasting? So we talked earlier about intermittent fasting, which is just one type of fasting. So this is a broad question, maybe somewhat controversial. Not controversial, but, you know.
Yeah, I mean, again, I actually study nutrition undergrad, so I'm a big believer on, you know, just on testing all of these things. Because again, everything that we do, we want to know that, are we going to hurt ourselves by doing this? Because first, do no harm, right? So the jury's still out on fasting, and if so, how often and how that should happen. But there's actually studies going on, which is great. So more to come on it. But I think right now, the only study that we have suggests that patients didn't do well. And I think, you know, certainly we would always want our patients to be drinking, to starve or have this intermittent fasting and not eat or drink anything can really do damage to our kidneys. So we don't want that. That would be a little bit dangerous.
Got it. Jesse says, what are your thoughts on supplements? And that's a broad question, what type of supplements, but in general.
Yeah. That's a great question, Jesse. I mean, I think that we actually do have data on this one. So I think all of us want to believe that the supplement will somehow go to our immune system and get us stronger and keep us stronger, where in fact, most data that we have suggests that the first place that supplement goes is the cancer cell. So cancer preferentially takes up these nutrients, just like the sugar or the fat or whatever it wants. It takes up these supplements too. So it's not like our own body can say, oh no, that's not for you, cancer, that's for my immune cell, you know?
That's a great point. Wow.
So you have to be really careful. And I always say, you know, it's not the vitamin C, it's the orange. So we, you know, I'm not a big believer on supplements except for vitamin D and calcium. And like you said, there's $1.5 billion industry right now. Like, I mean, actually several $1 billion. I think on our podcast, we said like 10, I mean, it's a number I couldn't understand on diets and supplements and other things. So I would just be mindful. And again, it's eating well, as opposed to, you know, anything in pill form that would make me nervous. But I would say that calcium and vitamin D, particularly for women and any men that may have trouble with bone health, is important. So that's an important one. And I think that there are some suggestion of some spices that probably won't harm. Not sure how helpful they'll be. So there are opportunities, you know, in most cancer centers, there are integrative medicine departments and folks that have trained in the East and the West. And I think that's important. So I think it's not like I'm saying, you know, thou shall not do any of that. I think it's important to explore. I just worry again that the idea that these supplements somehow won't go to the cancer is just untrue. And we do have data that it can.
Got it. Thank you for that. Bruce says, can the doctor explain how the disease affects our anxiety with our cancer?
That's a great
Good
question.
question.
Yeah, so I think that there's no question that their level of anxiety and depression, we have a couple of studies to show this, is higher in patients with neuroendocrine cancers. I can't tell you why biologically that happens, but I can tell you it happens. So it is something we always want to be mindful for. I have a few hypotheses or theories as to why that might be. One, how you feel is, how you physically feel can obviously affect how you feel emotionally. And so in some patients that, particularly in our patients that may have hormone related symptoms, it is exhausting to constantly having to go to the bathroom or to feel the flushing or just to feel unwell or to get abdominal pains that come and go. And so when your disease is symptomatic like that, whether it's from a hormone or just the disease itself, it takes its toll physically and emotionally. So I think that, hopefully you always have conversations with your docs on how you're feeling emotionally. I always say we take care of the whole patient, not just the neuroendocrine cancer. So I think, and when you're dealing with that for so long and so many years, it again gets exhausting. And so I think there's no question that there's a higher rate of anxiety and depression in our patients, whether that's a biological effect of the disease somehow affecting patients, or whether it's just that you've been having to deal with it for so long. And some of our patients that have lived for years with this chronic disease, I'm not sure, but it's real.
Got it. Thank you for that. Next question from Erica. Just started octreotide rescue injections, and I'm experiencing symptoms of hypoglycemia right after I give myself the shot. After about 20 minutes, it subsides. But what now? What can she do moving forward?
So that is a rare side effect of short acting. I would definitely touch base with your oncologist. Hypoglycemia is actually is dangerous. If you're not getting glucose to your brain, you can pass out, and there's a lot of things that can happen. So I think it's important to just touch base with your oncologist on that one and get an understanding of, is it important to take these rescue doses? Is there any alternatives that you can do? In the I would say older days, we used to, before starting the long-acting shot, do rescue doses for patients before we did it. We don't do that anymore. So I think the rescue doses can definitely be helpful in patients that have debilitating diarrhea or very bad symptoms. But I would just ask your oncologist, is this necessary? Is there another way to do this? Because I don't like when you have low glucoses. That's not so good.
Yeah. Folks, we got about 13 minutes left. We're going to keep pushing forward. Lots of questions today. Great episode today. Ernesto says, what is a way to know the carcinoid tumor, where the primary source is located? Where is the primary tumor located? My wife was diagnosed with carcinoid tumor, but not sure why the doctor says the primary is small bowel.
Right, that's a great question, and he's probably right. So the best way to know is if you look at regular CT imaging and you don't find the disease, there's often clues to get an understanding where it is. So for example, in some of our patients, there's what we call mesenteric lymphadenopathy. So the lymph nodes in the bowel. And when there's mesenteric lymphadenopathy, we know the first place that cells tend to go when it starts into the small bowel is the mesentery. So that picture generally suggests that it starts in the small bowel. If it's what we call peripancreatic lymphadenopathy, where there's a lot of lymph nodes around the pancreas or around the stomach, often that suggests it started in the pancreas. If you can't find the primary based on that regular CT or regular MR, generally, if you have access to a PET dotatate or the copper, whichever one is available at the hospital that you're being cared for, that will often find the primary to confirm. And again, it's often very small and it'll light up, and often we'll see it on the small bowel. But again, sometimes you still don't find it, but the pattern of disease can be very helpful in deciding where we think it started.
Got it. Thank you, Ernesto. From Marge, if you have one cancer, like a NET, does that mean you're more susceptible to other cancers?
No, which is great. So I think it's a reassuring to know that, just because you have one neuroendocrine tumor does not mean that you're going to potentially get a second. More concerning, that it could potentially spread depending on what your disease is and where it is. There was an early study that showed a potential association from the neuroendocrine tumors and the development of polyps in the colon. That doesn't necessarily change our management per se, except to say, if you're 45 now as a baseline, the guidelines just change that you should get a baseline colonoscopy. And that's important because, in colonoscopies is one of the only tests that we have that actually prevents a cancer. It's not looking for early detection. You take out the polyp, then you never get a cancer, which is pretty cool. So I would say that if you're of age appropriate time for screening for colonoscopy, I would do that, but there's no other additional screening that's required in a patient with neuroendocrine tumors.
Got it. Let's keep moving forward. Gail says, can you elaborate on active surveillance for NET patients?
Yeah, that's such a good question. So I hate to sound like the broken record on terms of like the heterogeneity of the disease and everyone is different, but I would say that less is more in our disease. And I say that for a couple of reasons. I think one of the struggles with our cancer is that unsettling feeling like, is it ever going to come back or not? Like we want to just be done with it and move on to the next play. And I think we all want to do that, but we know that there's a chance it can come back. The NCCN guidelines are so across the board, which is very frustrating because it says anywhere from 3 to 12 months, which is obviously a huge time frame. And again, it goes back to the patient in front of us today. So if you had a small tumor in the small bowel, for example, even if there's lymph node disease, I often will say, the first one maybe at 4 to 6 months, and then if it's negative, go to another 6 months. But the more time in between, the more comfortable we feel that we're truly not missing anything. Because what can happen as a radiologist, if you do too many scans, the 3 months to 3 months to 3 months to 3 months, it's just a lot of scans and potentially financial toxicities are high. And, there is some radiation, that's getting exposed for the CTs, not the MRIs, but the CTs for sure. And it gives everybody a comfort level to know if you're spacing them out and at 6 or 9 months, there's still no evidence of disease, the chances of you having no evidence of disease is really high. I will say I do not like blood work to monitor for disease recurrence. We do not in 2021 have a good marker to help us know if this cancer is there or not. There's too many false positives, and I've seen too many patients, unfortunately, and doctors go down the slippery slope of thinking that this elevated enzyme or chromogranin or whatever is, suggesting the cancer comes back. And if you don't see it on imaging, it's not there, for all intents and purposes. Like we can't treat anything we don't see. So I only do good quality imaging to see if the cancer comes back. And I'd like to space it out as much as we can. One, because most of my patients, myself included, it's a stressful day. That's anxiety of trying to do this. I mean, obviously, if you had a higher grade tumor and we're a little bit worried about it, then we do it more frequently. We never do it more than quarterly, though. 3 to 4 months is by far the shortest amount of time that you would want. And then we try to space it out.
Got it. Thank you.
Sure.
Karen says, when I was diagnosed in 2019, the CT scan showed 3 lesions in the liver, and I had a biopsy done on the liver. Then I had a PET scan, and was told there were 9 lesions. Too many to count. So my question is, did the biopsy somehow cause more lesions in my liver?
That's a good question, Karen. The answer is no. We've known for the last 30 to 40 years that our disease and its pattern of disease makes it very unlikely that you truly only have 3 tumors. For whatever reason, when our cancer comes back or if it spreads to the liver, it does so in a way that unfortunately there's just always a little bit more than we want to know about. Now, it doesn't mean that it's going to grow faster or anything like that. In fact, that's one of the reasons why we like to do what we call embolization, because it takes care of the whole liver as opposed to going in and cherry picking out these tumors. But there was a study 25 years ago where a surgeon went into the operating room and where they thought there were only 1 or 2 lesions, they just randomly took biopsies of the patient's livers and all these patients that they thought had resectable disease. And all the biopsies had neuroendocrine in it. It's so small and it's so slow growing that it may never do anything. It's just the true cancers that are only 3 lesions are pretty low. That's in patients where you can see the disease and where it's there, it's usually more. Again, it doesn't mean that it's going to start growing or anything like that. And so I tell my patients all the time, just because we have fancier tests now, like a PET dotatate or a copper dotatate, does not mean you have more aggressive disease. just because now you had 9 and you only had 3 before, it didn't mean the biology of the disease changed. It just means that we have fancier pictures now, but we may not have even ever seen those tumors. Sometimes these tumors they lie dormant for so long and they're never going to hurt us. So you just have to be very mindful of that and talk to your oncologist on like, what does that mean for me? Are we worried about this disease or not? Because often the answer is no, we're not. It just, we picked up more disease because these tests are more sensitive now.
Got it. Dr. Reidy, you're getting a lot of compliments in the comments.
Oh, thank you.
Especially about how you're explaining things, kind of echoing what I had said earlier, and people saying how great today's guest is. I have to agree. Stacy says, this is my first time joining, and this has been so informative and educational. Thank you. Knowledge is power. Stacy, thank you.
Knowledge is power. Thank you, Stacy. I love that.
This is our job, and we love to hear that we are doing it well. So appreciate you being here. And listen, Stacy, we're here every week with a new amazing expert in this field. So hopefully you come on back. Let's see. Ernesto says, when is zermelo indicated for carcinoid for a carcinoid tumor?
So zermelo is a really important drug in our patients that have carcinoid syndrome diarrhea that is not well controlled. So for example, on our patient earlier that had asked about rescue doses, maybe zermelo, if we're using rescue doses of octreotide for bad diarrhea, that may be a nice time to do that. So the studies with zermelo looked at patients with carcinoid syndrome diarrhea. And when you gave that medication in comparison to placebo, the number of bowel movements per day went down.
Got it.
So it doesn't completely eliminate it, but it does improve the symptoms. It didn't really improve flushing, unfortunately, but it did improve the diarrhea. So it's just for patients with carcinoid syndrome diarrhea that we use it.
So speaking of carcinoid syndrome, then Jill says, or has a question. I had a net and lymph nodes removed 8 months ago in mesentery. I thought once the tumor was out, it was over. I'm about to start getting sandostatin for severe diarrhea. Can you have carcinoid syndrome after the tumor is removed? I just don't understand why they're putting me on sandostatin now that the tumor is gone.
So I would say that's a great question. Again, this kind of goes back to what I was talking about earlier, where we have to ask the question of why you're having diarrhea. Do we know for sure that this truly is from carcinoid syndrome diarrhea? The best way to test that for sure is to do what we call 24-hour 5-HIAA. Kind of annoying. You have to kind of pee in that little, I'm sure everybody that has had to go through this. We give you this little hat where you can just collect for 24 hours urine, put it into a bucket, and then we take it to the lab and we look to see if the serotonin, which makes carcinoid syndrome, and the breakdown of serotonin, which is 5-HIAA, is elevated. If it's elevated, that means you absolutely have a carcinoid syndrome, and octreotide or lanreotide is the way to go. If it's not, if it's normal, it's not the perfect test. There's a chance that it could be false negative, but then I would look for other reasons for the diarrhea. So I think you want to, hopefully you did that and it was positive. It's pretty rare to have a major surgery and get such bad diarrhea if most of the disease is out. So I worry sometimes that removing the tumors and a lot of lymph nodes means you're removing a lot of bowel. And so it actually could just be post-op diarrhea, meaning more from your anatomy and your bowels not behaving so well, as opposed to carcinoid syndrome. So that's one I would touch base with your oncologist about.
Got it. From another Diane, does the tumor grade change after an embolization?
No, it's a great question, Diane. No, I mean, tumor grade, we know that there's heterogeneity of grade. And so, we know that within one patient, you may have some tumors that are low grade and some intermediate grade, but the embolization itself that we're aware of today doesn't somehow change the biology and make it a higher grade.
Probably going to be our final question. Effie says, can you talk about how lung nets affect the heart? What else can be affected other than carcinoid heart disease, which most people are somewhat familiar with?
Hey, Effie. So the most common by far is carcinoid heart, which is from the serotonin that can happen in lung nets as well as small bowel nets. Some of our tumors or patients can definitely have neuroendocrine metastasize to the heart, which is kind of scary. I don't know why it wants to go there, but it can. And sometimes it's in a bad place that we need to resect it. So particularly if it's there and you have the carcinoid syndrome, it may exacerbate the production of the serotonin that can hurt the heart in a better, in an unfortunate way. So if you can have what we call intracardial metastasis, and you can get the carcinoid syndrome heart. So those are the two most common sort of ways that the carcinoid can affect the heart.
Got it. Got it. Folks, I think that's going to be it for today, but I just want to say, Dr. Reidy, that our
Thank
friend
you so
Bruce
much.
says, Mr. Bennett, you do a wonderful interview. So our guest is not the only one with the with the love being shown today. Thank you, Bruce. I'm here every week, brother. No, Dr. Reidy, thank you so much. This
You're
has been
so
awesome.
welcome, Ray. Thank you.
And listen, everybody, we didn't get to, there was a lot of questions. So I'll reiterate, reach back out to Carcinoid Cancer Foundation. Maybe we get Dr. Reidy back on the show. But thank you for making the time. You have been a pleasure to work with. And this has been a pleasure. And again, like, you explain things really, really well. I appreciate that.
Thank you. And thank you to all of you. Stay safe and be well.
Absolutely. Thanks for joining us. As always, we hope this program helped answer some of your questions. Again, reach out to Carcinoid Cancer Foundation, either here or carcinoid.org if you have any other questions. The show will be evergreen here on the videos tab and on YouTube starting Monday. Thanks as always to Tercera Therapeutics, our presenting sponsor. We couldn't do this show without them. Finally, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next time for Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.
Take care. Bye-bye.